Hello and welcome to Inside Exercise. I'm Emeritus Professor Glenn McConell from Victoria University in Australia. Just finished the most remarkable chat with Professor Mark Tarnopolsky from McMaster University in Canada. He's done remarkable studies over the years, looking at sex differences with exercise, high intensity intermittent training, creatine supplementation, and all sorts of things. But he's actually a neurologist, and he is really focused on mitochondrial metabolism, and especially in people with various metabolic diseases, myopathies, etc. So looking at the effect of exercise in people with various muscle myopathies. Incredibly, the takeaway message is that pretty much all muscle myopathies can be improved by exercise. So depending on the myopathy, the exercise can be different, but generally across the board, exercise, whether it's weight training, endurance training, combination, will improve every muscle myopathy. So that just blew me away. So stick around. I think you'll really enjoy this one. Hi, Mark. Thanks for coming on. Welcome to Inside Exercise. How are you doing?
Very well, thanks. And thanks for inviting me.
You're a busy man. So I just say, as soon as just before we came on air, I was like, hang on. So you're a neurologist. You're running around doing that, seeing patients, plus all this incredible track record. So I actually put out on Twitter. I know you're not on Twitter, but that you've got an H index of 140 or something like that on Google Scholar anyway. So why don't you give us a bit of a background to yourself? So I know I've actually seen Michael Riddell said that you run and you cycle like the wind. So I'm figuring you're an athlete first, and then you got into to become a medical doctor and a researcher. Is that right, or is it the other way around?
Yeah, so I did all sorts of sports when I was a teenager and did some downhill skiing and football. Hard to believe when people know my body habitus now. And my plan was to be a phys ed teacher. So I came to McMaster in kinesiology, and I was going to go through and be a phys ed teacher. As I was going through, I became interested in medicine. And I said, well, I do tons of sports, and I got into orienteering, ski orienteering. I represented Canada and went to world championships. And I said, I really want to be a sports med doc. So did a bit of time in sports med clinics. And then I thought, I want to do research. So a little schizophrenic, I think. So I went into a PhD with Duncan McDougall and Stephanie Atkinson, sort of combining exercise and nutrition. And that was really interesting. And we were, probably the first to show that top sport endurance athletes needed more protein than the Canadian RNI. And back then, boy, I was lambasted. Vernon Young and all these guys said Tarnopolsky's full of crap. There's no increased protein requirement. So since then, when I suggested that top sport athletes needed 1.7 grams per kilogram, many studies have shown that that's in fact true. And that was my first paper in 1988. So then after I finished my PhD, I said, I'm going to go back and I'll do sports medicine. So I had the MD and PhD, and I was planning on first going into sports medicine. But then I thought, I'm really interested in neurology. So I did a year of internal medicine, then I went off to neurology, divorce and a few other things came my way. I came back and trained a little bit in what's called physical medicine rehabilitation. And when I finished my career, I really wanted to take everything that I'd learned with exercise.
Hang on, you finished your career. What did you mean?
Well, when I finished my training, I should say.
Oh, your training, yes. I think you're right in the middle of your career, yes.
Yeah, so I finished my training. I said, how can I put these together? So I started off teaching in the Department of Kinesiology, but then as a clinician, seeing patients who have muscle disorders. And I was thinking, what can we really do for these patients? And as it turns out, exercise, which we'll talk about today, and different nutritional interventions were really quite potent. So we've published papers showing the benefits of creatine and muscular dystrophy, and actually showed in Duchenne that was of benefit. And taking my background training in metabolism and mixing it with neurology and physical medicine, we're really looking at things like mitochondrial disease, for example. How can we come up with multi-ingredient supplements that improve function? How, for example, with a fat oxidation defect, can we bypass the defect with different nutritional supplements? And what exercises can we provide people to improve their function? So that's pretty much been my career, trying to improve function in people that have nerve disorders, muscle disorders, and metabolic and genetic disorders. And so all of my background in exercise physiology and nutrition and metabolism have really come together to try and optimize function for these patients.
Wow, that's really, there's a lot of stuff there, because I want to talk to you, make sure, because we're going to be talking about the exercise, but I want to make sure we get back and talk about the supplement side of things as well, on the nutrition side. You also did a whole bunch of early stuff So, just to point out to people that, I've already had Stu Phillips on here, the big name in protein. So you actually supervised him, right?
Yeah, Stu and I did our our graduate school together. And he went down and worked with Bob Wolf and then came back and spent a year with me as a postdoc. But at the time, I was sort of transitioning from more teaching into clinic. And there was only one position open. I was giving up my job at McMaster for Stu. But Marty Gibala, whom who's
also been
a researcher. And so it was a real existential crisis because we wanted both of them. So we had a little deal with Duncan and Digby and myself that I would resign. And then Duncan would delay a year so that we brought both Marty and Stu back to kinesiology. So that was really where things started. And then my first undergrad student, Johnny Parisi, is now the chair of kinesiology and he's the associate dean of research. So Johnny, Stu, and Marty really allowed our fine tradition with Duncan and Digby to really continue at McMaster. So they've really been taken over the reins of exercise physiology at Mac.
So did you say Stu was your first postdoc and you also supervised Marty Gibala, is that right?
No, Marty was coming back from a postdoc and they were both applying for my position. So I organized the field to get both of them together.
I'm slow there. Okay, and then the other thing is, because we've had both Stu and Marty on, so just a bit of a plug if people want to go back and look at those. Also, you've done stuff with Exokines in Copenhagen. You started off doing gender. What did you do there? Just a bit of a background. Well, now we don't say gender differences, sex differences.
Yeah, so back in, I guess it was as early as 1990, we started looking at sex differences in metabolism. And we did some studies with muscle biopsies looking at carbohydrate metabolism in men and women and showed that women oxidized more lipid and they spared carbohydrate, they spared glycogen, and they had lower protein oxidation as a consequence. So over the next several decades, we were looking at differences at the genetic level in terms of mRNA expression. And our conclusion was that women oxidize more lipid, and that seemed to be related to estrogen. So when we gave men estrogen, we showed similar changes in the RNA profile, which facilitated lipid oxidation. And so we think that that's really what's being regulated. Then carbohydrate and protein, follow as a consequence. If you have carbohydrate, you don't need to oxidize as much protein. So I haven't worked directly with Benta, but we've been certainly over the years doing overlapping research that was very complementary. And she's done just amazing research, which pretty much showed similar work to what we've done. But, she certainly expanded in different areas and buttressed support for a lot of the work that we've done. So I've got a lot of respect for the work she's done over the years.
Right. Oh, yeah. And you've mentioned creatine, so we'll probably get to that later with Duchenne muscular dystrophy. And you've done the HITT stuff. Well, I talked about that with Marty Gibala. Now, exosomes, people are going to be thinking exosomes. Now, we did talk about that. Can you just give us a quick 2 seconds on that, and then we move on?
So people are probably familiar with exosomes, which are felt to be intercellular communicators. So essentially, when we have cellular debris, it can go into the lysosome, and the exosomes are either a source of release of some of the damaged material from the cells, or can be functioning as a release of a signal, very much like an endocrine signal, which can either be autocrine, paracrine, or endocrine to communicate to other tissues. We were very interested in exosomes for a while as a method of gene delivery. And so we did a lot of work trying to load them with electroporation or different lipotransfection methods and put mRNA into exosomes and use them as therapy. It worked wonderfully in vitro, but one of my patients who had mitochondrial disease just happened to have had a bone marrow transplant. So I came up with the idea that, okay, if we can ever use exosomes as therapy, this person's a perfect embodiment because now their bone marrow is a production site of exosomes. So essentially it's like a bioreactor, but these exosomes are labeled because they have the mitochondrial DNA haplogroup of the donor. And we can see if this whole exosome therapy would work, is mitochondrial DNA from the donor should have then gone into skeletal muscle or other tissues. So we sampled 3 of the 4 tissues in the human body and saw no evidence whatsoever that the bone marrow derived mitochondrial DNA could end up in terminally differentiated tissue like skeletal muscle. So that sort of was, one of the things that quelled our interest in using exosomes as a form of gene therapy. Now, it may be that, and it's likely that, the exosomes that are released in response to exercise, which we and others have documented, you get this doubling of exosomes, and about 50% seem to come from skeletal muscle. They likely have some signaling function. And certainly some of the evidence that if you take young exosomes and put them into older mice, you can see some youthening of the tissues. So there's probably some almost the parabiosis experiments, which I'm sure you remember from the serum. It may be that exosomes are actually transporting some of the small RNAs and proteins, which are responsible for some of those beneficial effects that were known years ago when they did the parabiosis experiments between younger animals.
Right, because we've got a bit of a mixed audience, I'll just make sure people haven't been lost there. So basically the exosomes are, you have sort of plebbing off from the cell, and you're saying like from the cells, and about 50% from the muscle. So the idea is with exercise, you're exercising, some material from the muscle is actually able to come out into this sort of exosome thing that can float around the blood. And you've shown, and others, I think, that these exosomes can be taken up by all sorts. You found them, I think, testicles and all sorts of things, that these other cell types can take up this messages that are coming from the muscle, and maybe that's how the body, partly how the body knows that you're actually exercising. Is that a fair comment? Or?
Yeah, I mean, certainly, Bente Peterson is, and Mark Fabreo from Australia are, really the leaders in looking at this signaling, the so-called myokines, where you release substances, and they were the first to document interleukin 6, which comes from muscle. Some, but probably not all of that could be contained within exosomes, and that's still a little bit unclear. I think some of these signaling molecules that are released from muscle, we've done some work on interleukin 15, for example, are released directly into the plasma, but others are contained within exosomes. The exact proportion and which ones are within these little lipid balls called exosomes, which are about 90 nanometers in diameter, versus which are free in the cell surface binding to receptors, is still a little bit unclear. But there's certainly a wealth of information, I think, that's going to be coming on those areas over the next few years. But clearly, they are likely involved in some forms of intracellular communication. Probably the best evidence for it is in a paracrine signaling fashion. So, for example, in the brain, from one cell type like an astrocyte going to a neuron. So for shorter distances, probably a little bit more relevant than for the endocrine function.
Okay, so you're saying it's more likely the short distance rather than going in the blood, traveling to other tissues.
The data is strongest, especially in the central nervous system, for the short distance paracrine function. But clearly there is some evidence that especially young exosomes derived from blood from young individuals, especially post-exercise, do have some beneficial effects. So clearly they are transporting something. Exactly what that cargo is still needs to be, I think, further elucidated.
Has that been shown in animal models or humans or both?
Well, in humans, it's very early, and a lot of the research is completely contaminated by very poor exosome isolation methods, which we don't get into too much. But clearly, I think the purification has been a big issue, which has hindered the whole development of the field. And, we have in our most recent paper, which was on the effect of aging and exercise on exosomes and small microvesicles, we've documented different isolation methods to show how using a thing called size exclusion chromatography gives you a much more pure fraction. Problem is, it's a very small number, so it makes it hard to identify the cargo.
All right, that's good. So you've got to do the due diligence. You can't just sort of whack them in and nothing happens, and you say, well, they're not doing anything. You got to make sure you're actually purifying them in there.
Well, this is the thing, because is it a microvesicle? Is it actually contamination from the actual plasma or serum itself? Or is it actually exosomes? And separating those out is something that I think a lot of people weren't doing initially. And so a lot of the effects that people were attributing to exosomes may in fact be microvesicles, or it may be actually proteins that are free in the plasma. So I think as we move forward with better isolation methods, we're going to know more about this.
All right. So I know this isn't the brief, but part of the reason I'm doing it is because initially that's what I was going to ask you to talk about, and then you said, let's talk about this. One last thing, does it cross the blood-brain? Do the exosomes, they can cross the blood-brain barrier? They can get into the brain from the periphery, is that right?
Well, that's the whole theory, and that's where we were excited from a therapeutic perspective, because, for example, with lysosomal storage disease, which we'll bring up when it comes to exercise, other than Pompe disease or some of the mucopolysaccharidoses, many of them affect the central nervous system. but a regular protein just doesn't make it into the central nervous system. So when we provide enzyme replacement therapy to replace the missing enzyme in Pompe disease, for example, it will not cross the blood-brain barrier. So exosomes have been shown in animal models. Obviously, it's difficult to do in humans, that they can traverse the blood-brain barrier through a process called transcytosis. So that's why we were quite optimistic. But even the very early work, and probably the world leader in the exosome field is Dr. Matthew Wood from England. Even his work, if you label the exosomes with a fluorescent tag, most of them end up in the liver, in the spleen, and in more of the inflammatory type tissues, with very little crossing the blood-brain barrier and muscle.
Okay.
But that may be a targeting issue, but generally most of them do end up in the liver and spleen.
Right, great. Right, so today we're talking about exercise for myopathy patients, and then inverted commas, my doctor told me it would damage my muscles. All right, so that's interesting. So it's implied in there, I guess, that it doesn't damage your muscles. But so why don't we start talking about that? But how about just at first we just sort of define, like, what is myopathy? What does myopathy even mean? And what are the different myopathies? And, just a bit of a background before we start talking about what does exercise do.
Sure. So myopathies are disorders that can either be acquired or genetic. The acquired disorders, for example, would be certain deficiencies, and even severe vitamin D deficiency can call a myopathy, which is called rickettsic myopathy. You can have, for example, inflammatory disorders, which are under that acquired umbrella, things like dermatomyositis, polymyositis, and inclusion body myositis, which, as the itis means, those are inflammatory disorders, very much like rheumatoid arthritis or lupus of the skeletal muscle. There can be toxic myopathies, which are also acquired. So, for example, statin medications are probably the one that most people are familiar with. So statins can, possibly through depleting coenzyme Q10, but more likely through alteration of post-translational modifications, lead to an acute necrotic myopathy. Interestingly, more recently, we've found that people who take statins, a small fraction, can develop antibodies against HMG-CoA reductase, which is the enzyme which is blocked, and then they can turn into an inflammatory myopathy. So there is an autoimmune form that can come out of a toxic myopathy from the statins. And then on the other side, what I deal with more are the genetic myopathies. And within that group, we've got the limb girdles, as the name implies. It affects the proximal muscles of the arms and legs. We have facioscapulohumeral muscular dystrophy, which affects the scapular muscles, the face, and also the foot dorsiflexors. And then there's the myotonic group. So there's myotonic type 1, myotonic type 2, and there's other things like paramyotonia congenita, which are all genetic mutations, which either affect the irritability of the muscle. For example, the myotonic dystrophies, you get a cramp or a spasm in the muscle following contraction, but ultimately we get what's called a dystrophic process, which is damage to the muscle, which then causes connective tissue to come in, fat tissue to come in. And of course, if you have less contractile tissue, you end up getting weak. And those are the dystrophic processes like Becker's and Duchenne, limb girdle 2A, 2B. It's all the way up to Z. We have to get a new alphabet. There's so many of them that have been discovered now. But ultimately, these lead to fixed proximal weakness and or exercise-induced issues. And then the latter exercise-induced issues would be enzymatic defects that affect muscle. Things like McArdles disease, where you can't break down glycogen through myophosphorylase. Things like PFK deficiency, where you can't flux through glycolysis. And those are manifest with cramps and rhabdomyolysis, which is the breakdown of muscle in response to higher intensity activity. And then the more endurance deficits would be things like a fat oxidation defect, like carnitine palmitoyltransferase 2 deficiency, where you don't bring long-chain free fatty acids into the mitochondria, or some of the beta oxidation defects. And those usually manifest with fasting or with longer duration exercise. And then finally, a whole group, which is my main specialty, are the mitochondrial disorders. And many, but not all, do affect the muscle, either with a fixed weakness, but more commonly, severe exercise intolerance with a massive reduction in VO2 max.
All right. So it sounds like from what you just said, some of these things, I'm just stepping ahead a bit here, I guess. Some of these things are going to be improved by exercise, perhaps, but some of them you've actually already indicated exercise makes things harder. Is that right? But,
Yeah.
but can they get a tolerance to that? You know, obviously it depends on the disease, but people that can't tolerate exercise, can exercise make them tolerate it more? Do you know what I mean?
Absolutely. So,
Okay.
for example, with McArdle disease, I'll just give you an anecdote and then I'll give you the science on this. So we had two young men who came to me who had McArdle disease. I could tell from their history, whenever they did activity within 20 to 30 seconds, their muscles would go into a cramp. They had multiple bouts of dark urine, which was tea-colored because they were breaking down the muscle and getting classic rhabdomyolysis. So the two of them went to a summer.
Can I clarify? Was that after, did you just say that was after just submaximal? What was that?
That was when they did the rest exercise transition. So the example where it was really classic is they went to a summer camp, and it was a water ski camp. So with a water ski, you can imagine, if you've ever done it before, it's like the most intense isometric contraction. So you're totally dependent on glycogenolysis and glycolysis. And every time they would start the camp, they would talk to each other because they were brothers, and they'd say, "Dude, are you peeing black urine?" He said, "Yeah, dude, I'm peeing black urine. We must be a bunch of wusses." And he said, "Well, if my brother does it and I do it, we're just out of shape." So what would happen is they would keep doing it because they didn't want to appear to be, babies. And so within a few weeks, they were able to water ski for 2.5 minutes with a maximum isometric contraction. And by the end of the summer, they didn't have any symptoms at all. So again, we later showed that they had a common homozygous variant for McArdle disease, and they definitely had McArdle disease.
And they had no idea, obviously, before that. They just thought that's why they were.
Decades later when I made the diagnosis. And one of the fellows became more sedentary. The other fellow always continued exercise, and he actually made it not quite to junior A, but he was sort of the second tier down in hockey. But hockey, again, would be probably the worst disease for McArdle disorder, because you're sprinting and you're doing 30-second bouts of exercise.
You can't break down, just to make sure people know, you can't break down glycogen, because like you said, you've got glycogen phosphorylase is missing.
Exactly.
So you're having to rely on glucose uptake and glucose use, fat use. Maybe they use a bit of protein. Okay, keep going. Yep.
Yeah. So what's interesting is the Spanish group has clearly shown that which we've shown as well anecdotally, but they've shown in many studies, that if you start off at a lower level and you gradually get the person accustomed to exercise, people will eventually start to adapt. Because if we think about the canonical adaptations to exercise, increasing the ability to oxidize lipid, right? And increasing capillaries. And so for these patients, what happens is they get into what's called the second wind. And the second wind, what will happen is they'll start to get spasms and tightness when they can't do anaerobic glycogenolysis. And then if they ease off a little bit and take the time to ease back into the exercise, eventually as your capillaries dilate and you start to bring blood-borne glucose and almost certainly free fatty acids, and possibly, we haven't studied this yet, but branched chain amino acids could be utilized as energy in these folks as well. They get into this second wind phenomenon. And what happened is, as you start exercising and training, and you're actually increasing the ability to get into that second wind. So, for these individuals, the classic mitochondrial biogenesis, increased capillarization, increased utilization of free fatty acids, all of those things were adaptive for these patients. And, many of us have clearly shown that we can exercise train people carefully. And John Vissing and Ron Haller, who are two of my colleagues who work in this similar area, have clearly shown also that if you give pre-exercise glucose, usually within about 15 minutes before, the rate of appearance of glucose into the plasma then can be taken up. And if you're starting to exercise, you don't trap it as glycogen, which you can't break down, but you can just flux it down through glycolysis.
And take it during exercise as well, I guess.
Yeah. So what we tell our patients is, look, listen to your body. If you start to cramp, immediately back off, take the time to get into the second wind. But what people find is that threshold slowly bumps up. I mean, it's classic exercise physiology adaptation 101. And it's been clearly shown to be beneficial for patients with McArdle's disease to do initially endurance exercise, but we've even had them do weights. And what we do with the weights is you don't do the standard, 12 to 15 reps. You do 6 to 7 reps. Because you want it right. You're doing mostly phosphocreatine. And Matthias Borgert, a colleague of mine in Germany, did do some studies with creatine, where they creatine loaded patients with McArdle's disease and did show improved exercise capacity. Unfortunately, you would think that creatine would be the perfect supplement for somebody with McArdles disease. But the problem there is that for phosphocreatine to be broken down, you need a proton. And the proton normally comes from
glycolysis.
Yeah, so you don't get the proton coming in, so it limits the ability. And Peter Hochachka, whom I'm sure you're familiar with, from UBC, who did a lot of enzyme kinetics, has shown that high concentrations of free creatine can inhibit PFK. And we've shown in our work that there's an upregulation of PFK, as you can imagine, in McArdle disease, to allow for increased flux through glycolysis to bypass.
I just say that again. I was just thinking of something else. So tell me again, the creatine can inhibit PFK?
Yeah, so Peter Hochachka in 1977, I believe, showed that high amounts of free creatine can actually inhibit PFK. And so,
so just so people know, that's the rate limiting step usually in glycolysis.
Yeah, so I think that's probably another reason why it's not as dramatically beneficial. I mean,
so sorry, even though they can't break down glycogen, you're saying that the creatine is going to inhibit phosphate kinase, which is an important rate limiting enzyme in glycolysis. So you're saying that's actually going to mess up the glucose use? Is that what you're saying? Or?
Well, a little bit helps because you can increase use of the phosphocreatine. But Matthias Borgert also said, well, if a little bit's good, more is better. So they went to really high doses of creatine, sort of the 20 grams per day.
Yeah.
And they found that the people actually did worse. But the reason why I think the McArdles patients did worse with really high doses of creatine is that very high dose likely inhibited PFK. And our work has shown that PFK upregulation is a compensatory strategy of McArdles patients. Normally, that's what the body does to try and compensate for McArdles. And so with the super high creatine, it actually inhibited PFK. And that's why
they can use more glucose, because the glucose is also coming through glycolysis. Is that what you're saying? Because they can't break down glycogen. They need the PFK to break down glucose, to get the glucose okay, perfect.
Yeah,
all right,
because compensation is to upregulate glucose up
more
through glycolysis.
I just want to make sure people are clear, because they'll be like, some people will be like, hang on, but glycolysis is no good because you can't use glycogen anyway. But you're saying you're going to use the glucose, so you need to still use glycolysis. Yeah.
Exactly. Yeah.
Now the thing where I lost my train of thought, I was thinking, hang on, because I knew there was something about, is that we used to always say that part of the thing about creating phosphate is that it helps to buffer your hydrogen ions, but apparently that's only very small, because it's like you said, it's creating phosphate plus hydrogen ions goes to, and you made the point that they don't get the hydrogen ion from the lactate. Yeah, okay, that's kind of complicated.
Exactly. Phosphocreatine plus ADP plus proton, right? So
and they don't get the proton.
Get the ATP, you need the proton to drive it in that direction, right?
Exactly. Wow. Okay. And you don't want to just give them protons, because that'll screw them up as well. You don't want to just give them
they give them some acid, a bunch of acid
loading. All right. Well, that's very interesting. I literally got a shiver up my spine when you were saying that stuff. That's just my mind's been blown already. We're only about 20 minutes in.
Yes.
Saying that the exercise, the second wind sort of thing. Yep. So.
Yeah. So another point along the so with our patients from an exercise perspective with glycogenolytic and glycolytic defects, it's a little bit different. So for the glycolytic defects, if you were to provide them sugar right before exercise, it makes them worse. Because let's say you have PFK deficiency or GSD type 7 or Tardieu's disease, same thing. So you have no PFK. So then if I provide glucose just before exercise, it's useless because I can't use it as energy. So all it does is it will inhibit lipolysis and proteolysis. So all of the things that you're using from a compensatory perspective are blocked. So again, Ron Haller and John Bissing showed that in the glycolytic defects like PFK deficiency, which is the most common of those, giving glucose before exercise makes them worse. Yes. So I have several patients, it's more common in the Ashkenazi Jewish population. And I've got one fellow in particular who is a really good weightlifter. But what he does is he starves overnight. He goes to the gym in the fasted state after a 12-hour fast. He works out, but again, he does the sort of 6 to 7 reps. So he's working mostly on phosphocreatine. And of course, since he met me, he's creatine loaded as well. And then he eats afterwards. But he can only work out if he has fasted overnight, because of course your rate of appearance of free fatty acids and amino acids are higher. And so for our PFK patients, it's just a little different when you exercise around the timing. and your nutritional strategy beforehand. But of course, for them, we give them creatine as well.
That's great. So just to make sure people are clear, so yeah, so when you're fasting, you're going to have higher free fatty acids, lower insulin, more able to burn fat is what you want. And he actually came to that by himself, or did someone tell him that?
He totally just
Fast
discovered
overnight.
it, because he found every time he ate before he worked out, he would cramp more, and you would have more pigmenturia, more
And
rhabdomyolysis.
did he know he had a deficiency of any sort or not? Did he know he had a problem?
Not until he saw me, yeah. And then
Wow.
we made the diagnosis, yeah.
And then it kind of made sense. And I guess you were able to say to him, well, that's why fasting was.
Oh yeah, it's and we've seen him now for the last 10 years, and he's still lifting weights, doing well. And since he's met me, and we've been strict about the diet and his exercise, he never does more than 7 reps. And we've started him on creatine, and we check and replace his vitamin D and all the usual things we do with our patients. He's had no bouts of rhabdo in the last 10 years.
Okay, yeah, I want to talk about the rhabdomyolysis. I just want to make sure people are clear as well, because not everyone's going to remember the creatine phosphate, phosphocreatine, as you say. So this is the idea that when you break down, people know about anaerobic and aerobic exercise. So when you break down anaerobically, you can be breaking down glycogen. It's mainly glycogen to lactate. Also, you can have glycogen going into the mitochondria and be broken down aerobically. Same with glucose. But the other one is creatine phosphate, which is anaerobic, broken down, although it is getting turned over in the mitochondria, etc. But the point there is that you're saying, because we generally say creatine phosphate can sort of last about 10 seconds or so. So you're saying if you do like 6 or 7 contractions, you're able to mainly focus on creatine phosphate, and then you resynthesize that during the recovery, and then you go again, and you're not having to rely so much on glycogen, which the rest of us would be able to do if we kept doing more than 6 or 7 contractions.
Yeah, because a patient with a PFK deficiency, so their glycolysis doesn't work, their mitochondria are fine. And generally, when we break down phosphocreatine, it takes about 2 minutes for it to resynthesize.
Yes.
And phosphocreatine resynthesis is dependent on mitochondrial function. So what you do is a circuit set, never do a standard set. So let that muscle recover for at least 2 to 3 minutes, so your phosphocreatine will restore. And that's the protocol that our PFK patients and our McArdles patients do, and they seem to do quite well.
And by doing aerobic type exercise, they'll improve their mitochondrial function and maybe improve their resynthesis of creatine phosphate as well.
Exactly. That's a general theme that we have for most of our patients, is that the evidence is probably strongest if you look at all of the data for an improvement in muscular dystrophy and other myopathy patients with endurance exercise. And again, improving fitness, improving function, improving your mitochondria, lowering your risk of type 2 diabetes, because most of our patients live a normal lifespan. So we have to think about obesity. We have to think about mitigating all of these metabolic disorders. It's very important to improve your fitness. But it's a very good point that you brought up, is that if you're doing weight training too, that resynthesis of phosphocreatine is dependent on good mitochondrial function. And so that's also important, because generally what we do is we like to have endurance, 1 day, resistance, endurance, resistance, so that we're usually doing 2 to 3 bouts of more resistance training per week and 3 bouts of endurance training per week. And it's very similar to what we and others have shown with sarcopenic older adults. It's really, you want to mix a little bit of both.
Interesting thing, I guess I was thinking is it's not if you actually know your biochemistry, and it actually, things just make sense, don't they? Like, okay, what's the deficiency? Like, it's not like this. I guess what I'm getting at is, I guess I figured like everything would be screwed up when someone's got like a deficiency of a particular enzyme. I don't know why I thought that. I thought maybe compensations or something. But are you saying that basically, if you're PFK deficient, everything sort of makes sense? If you just think, okay, PFK is missing, there's nothing else sort of, do you know what I mean? There's not like weird compensations or whatever, or...
Yeah, I mean, the body always compensates, to a large extent for most of these disorders. But again, and this is why I found it so exciting doing my PhD in metabolism, because then when you deal with metabolic, genetic, neurological disorders, as long as you know the pathway, you can conceptualize what might work for this person. And really, it makes a lot of sense. If you think about the glucose pre-exercise, when John Bissing and Ron Haller first showed that in the PFK patients, they got worse. Well, of course, it's all
because it makes sense.
Yeah, it makes sense. And our fat oxidation defect patients. So the flip side of McArdles and PFK deficiency is fat oxidation. So we had one fellow who came to me who had multiple bouts of rhabdo from South Africa. And in South
Sorry, why don't
Africa,
we just make sure people are, because rhabdomyolysis has come up a few times, just make sure people are actually clear on that. And maybe a lot of people would have heard about this, muscle meltdown or whatever, people, I don't know, running in a hot day, and maybe just give a bit of a background. You can actually die, you can affect your kidneys, etc. Maybe just give a bit of background on it.
Yeah, for sure. So rhabdomyolysis is essentially muscle breakdown, and it's operationally defined as a CK elevation more than 10 times the upper limit of normal. CK is creatine kinase, so it is an enzyme inside our muscle. However, if we have damage to the muscle, although conveniently we use CK as a marker, everything like ALT, AST, LDH, any enzyme that's inside muscle is going to spill out into the blood. Yep. Why that is a problem is that if it comes into the blood quickly, there's a protein called myoglobin, which is enriched, and it helps us to extract oxygen into our muscle. When that goes into our blood, it can actually damage our kidneys. So in the kidney, it can increase what's called oxidative stress. We can get fragments of tissue, cells that get jammed in the kidney, and we get what's called acute tubular necrosis, which means we damage the kidney, and you can go into kidney failure. And that can be fatal because our kidneys, when they're not working properly, our potassium can go up. We can get heart issues. And we've had people go on dialysis for weeks and weeks when they've broken down their muscle acutely. Wow. A lady with McArdles disease, for example, who didn't have a very pleasant husband, who was kind of lazy, and made her go out and shovel the driveway. I can't think of anything worse. Wow. And the poor lady called me on the weekend and said she hadn't peed in 24 hours and wondered if that was a problem. Oh. So I told her to go to Emerge immediately, and she ended up on dialysis for months afterwards because she had broken down her muscle so badly. So that's the worst thing that can happen for rhabdomyolysis. Now, again, many people who get rhabdo don't have a metabolic or genetic myopathy. Any person can push themselves into that state, and there's huge variance. In fact, the late Priscilla Clarkson was the first to show huge inter-individual variability, where, for example, if we bring someone into the lab and we get them to kick on our machine 100 times, some people's CK will go up a tiny amount or not at all because there's damage to the muscle. Yep. We've had other people who've almost completely necrosed their muscle, and their CK goes up, to 50, 60,000, the normal being 200. So those are in healthy kinesiology students we bring over. But when we see those extreme and recurrent bouts happening to people time and time again, that's when we start to think, could there be a metabolic or genetic myopathy? Yeah. Those are the people we bring into the clinic and take a look genetically. But again, every person in the world, especially an athlete who gets married, has kids, starts their job, and doesn't do much for a while, but your brain says go, you go back, and there's the guy with a barbed wire tattoo beside you in the CrossFit gym, and you try to keep up with him. The first time you go back, boom. That's what I see probably 9 times out of 10 in the clinic when someone comes in for rhabdo. It's not a metabolic disease. Cute thing.
I've actually got my own little example there. I my infinite wisdom, I actually had a reason for doing it, but I won't go into it. Even though I cycle pretty much every day on the Swift, the indoor, with the wiry kicker and all that stuff. Even though I do that every day, in my infinite wisdom, I decided just off the bat, but I did have a reason why I went to do it, to go, you know what, I'm going to do a 24-hour ride on my bike indoors, Swift. And I did. Anyway, the last 6 hours, well, I couldn't sit down very well for probably 12 hours. But the last 6 hours, I was literally, like, my tibialis anterior is like gone. And I couldn't keep my foot, because having to hold your foot up while you're pedaling. So I was literally like limping on the bike for the last 6 hours. And anyway, needless to say, I spent 3 days in bed, just couldn't move at all. And my urine was red. And I was like, hang on, this is just this tiny little muscle. That was the only thing that was sore.
That's
so I can imagine if you're doing a bucket load of damage.
Oh, yeah. Yeah, so that's what rhabdomyolysis refers to. And so anyone, if you do unaccustomed exercise, even if you, as you pointed out, if you're a good athlete, if you change what you're doing, for example, when I did a lot of cross-country skiing and I was racing at a high level, all I was doing was skiing all winter. And then, you jump back, your VO2 is, super high, you feel great. Then you try to run a 25K race and you push yourself too hard. I'd be peeing dark urine for 2 or 3 days afterwards just because of shifting. But then if I keep training, within 3 or 4 weeks, my muscles are no longer sore. Again, the classic adaptation that Priscilla Clarkson showed, decades ago.
I know. I remember she used to do 70 arm extensions with the eccentric, and I was like, holy crap. Actually, I just want to ask very quickly, because Michael Riddell, who was, I think, the second person on the podcast who talked about type 1 diabetes and exercise, said that you run and cycle like the wind, and you do look like a fit chap. So tell us, what do you actually, do you compete?
I thought I was a football player and a downhill skier when I was in high school, but my coach said, Mark, you got to go into endurance sports. So in university, I got into ski orienteering and represented Canada at the World Championships in ski orienteering. And I said, the bugger was right. So I had a muscle biopsy, 83% slow twitch fibers.
Okay.
Yeah. And it's almost like a congenital myopathy. But I'd subsequently gone on to race professionally as a duathlete and won a number of races. I've represented Canada in winter triathlon, won the Ontario Trail Running Series multiple years in a row. My highest VO2 was 87.6. So
what?
I had
was that calibrated properly? That's ridiculous.
Absolutely.
Sure?
Yeah.
No, I know you're a good researcher, so I have to take your word for it.
Well, it was Duncan McDougall. We had a CSEP certified lab. So I've had it measured over 80 at least 8 times. Barry Shep, he's the national coach for Canada for triathlon. And he did his master's with me. And so we were doing all sorts of testing of all the top triathletes in the world.
How old are you now? What's your max now?
I am
Don't mind me asking.
Yeah, I'm 60 years old, and unfortunately, VO2 has dropped down to 70, which sort of sucks. But
it's still 70.
What can you do? Yeah.
Okay, so you are.
We did a run from 870 kilometers from the top of the Bruce Peninsula down to the bottom, and we set the new record. That was about 6 years ago, so I guess I was at 54 when it happened. But unfortunately, I've had 3 cardiac ablation surgeries. My right leg's been reconstructed from different accidents and stuff. But the cardiac ablation is from too much endurance sports.
Oh, really? Well, I did have Ben Levine on.
Oh, yeah.
About can too much exercise damage the heart? But maybe let's not go into that, because it's slightly controversial.
No, let's not go down that pathway. After 3 cardiac ablations.
But you're suggesting it did. Okay.
Oh, God, yeah. Well, I mean, there's data out of Norway that there's a 5-fold greater risk of atrial fibrillation in top sport endurance athletes. But yeah, I've represented.
Yeah, there is, but it's not increasing their risk of death. What I mean is, it's not what he was saying. Oh, anyways.
No, it doesn't. My point is, and my whole life is about exercise is good for lifespan extension and health span extension and all that stuff. So in spite of that greater risk, we're not at greater risk of cardiac death. But get an ablation is wonderful. It took me from just being absolutely devastated. And actually, Banks' team was right, because I always used to argue that it was peripheral adaptations that were most important for VO2 max. But when I went into atrial fib, I can tell you, your VO2 drops by like 40%. It's horrific when you go into atrial fib, because you lose the preload, right? So you decrease cardiac output. Yeah,
and those studies where you crank up, it was like Phil Golnick, where he cranks up the pacemaker and he put up his VO2 max. You haven't tried that one? No, you haven't got a pacemaker.
No, I'm totally blunted now. I've got no vagal tone, because they cooked it when I got my surgery.
Oh, so does that mean your max heart rate's higher? No, I wouldn't do that.
Yeah, my resting heart rate used to go down into the 20s when I was really fit, but that's part of the problem. And they say that's actually part of the benefit from the ablation surgery, is that you cook your vagus nerve. So now I'm 70.
At rest, just like a textbook untrained person.
It's awful. It used to be down into the 30s.
20s, that's nuts. Yeah, I was 36 at one stage. I thought that was pretty good. All right, that's great. Now, okay, so should we talk about, I can imagine we could talk about all sorts of different diseases and exercise effects. Did you want to talk about a couple of, I know mitochondrial diseases we haven't really talked about, that's your main thing.
Yeah, so some of the areas that have been studied well, for example, where people would think exercise wouldn't be beneficial. The first, of course, is mitochondrial disorders. And it's one of the canonical symptoms of our patients that they have exercise intolerance. And in fact, the flip side to high VO2 are patients with mitochondrial disease. So we did a study in patients with something called MELAS syndrome, which just is an acronym for mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. But when we brought folks in, and this was our first creatine study, we had them on the bike doing a VO2 test, and the VO2 max in these patients was 8 mils per kilogram per minute. 8 mils per kilogram. And again, flip side was the machine calibrated. Their RER in some cases was over 2. It was
Oh my
crazy.
gosh.
Yeah, and
So lots and lots of carbon dioxide and very low oxygen. So yeah, the RER is above 2. Wow. Okay.
Yeah, and again, a daughter of one of those patients who did our first study, unfortunately, that the mom died a few years ago, but her daughter came in and had exercise intolerance. We put her on the bike. Her VO2 was 12 and her RER was 2.1.
Wow.
Just,
okay.
so
So just so people know that the respiratory exchange ratio, I just clarify that sometimes, is, and we always say if your RER is 1 during exercise, you're using pretty much 100% carbohydrate. If it's 0.7, it's 100% fat. 0.85 is 50-50. And what we often say at the end of a VO2 max test, because you hyperventilate and you blow off carbon dioxide, we often say like, you should have an RER of about 1.1 or something like that. Now you're saying theirs was 2 or more.
2.
So you literally double carbon dioxide and oxygen. So double the carbon dioxide production compared to the oxygen consumption. Right. So they've obviously got very low oxygen consumption. But are you saying they're compensating by hyperventilating to the crowd as well? Or?
Yeah, and so Ron Haller, as with Tanya Tavasalo, who was a postdoc working with him, who did most of this work, they've clearly shown a very hyperkinetic circulation in these patients. And in fact, when you do a forearm exercise test, when we put a catheter in, when you start exercising, what will happen is that the blood will usually go very deep purple because it becomes deoxygenated. Mm-hmm. In mitochondrial disease patients, because they cannot extract the oxygen, you actually find that you arterialize the blood. So it goes through so quickly and with that increased hyperkinetic circulation, but you don't extract the oxygen. So you actually get an arterialized blood sample coming out, which is interesting.
Wow. So it actually has, if anything, more oxygen or just the same as what came in almost, because they're not extracting much.
Yeah, because they're just not extracting it.
Wow.
Yeah.
Okay.
But anyhow, so what would seem antithetical in these patients is, well, if they have so much exercise intolerance, they should just sit around and not do anything. But Tanya has clearly shown, as did first author Jeppesen, who's working with Bissing's group in Copenhagen, showed that if you do endurance exercise training in these patients, you will increase VO2 max, you will increase the workload. And when they did muscle biopsies, they actually showed that there was mitochondrial biogenesis, and they've actually compared it simultaneously to healthy individuals training at the same time and showed that the increase was very similar in mitochondrial patients. However, when you're starting at a VO2 of 8, 9, or 10 mils per kilogram, an increase of 50%, it increases your quality of life. Which has clearly been shown in the studies where they use things like the SF-36, which is a quality of life score. That, of course, if your daily threshold of VO2 max is 12 mils per kilogram, people have estimated that that's what you need just to maintain independence in your activities of daily living. So if you can bump that up to 15 or 20, what you and I take for granted now becomes not your maximum, it's submaximal. So you can tolerate your daily activities more. And that's where the benefits in these severely affected mitochondrial patients come from. Even a small improvement in their VO2 max has a huge impact on their daily activities.
That's amazing. Yeah, because I guess to remind people or people that don't know, we usually say 3.5 mils per kilogram per minute is your basal sort of metabolic rate. So you're talking about people that have 8 or 12, they're sort of like 2 or 3 times their basal metabolic rate. So you would be using that just walking around, or
exactly
maxed out just walking around.
Well, in fact, in our first study, what we found is we had one lady who was a nurse. I don't know how she could continue to be a nurse, but somehow she could. And we put her on the bike. We had 0 watts, like just spinning the pedals. And her RER was 1.76 after 33 seconds on the bike, and she couldn't go any longer. That was it. She was maxed out with 0 watts. She was just spinning the pedals.
Just turning
the exercise intolerance is quite profound in our patients. So with the mitochondrial patients, no question, endurance exercise is beneficial.
Yeah, sorry, but how is that working? I guess it depends on what the mitochondrial, because obviously you got to think about what is the defect. How are they increasing their VO2 max? I know VO2 max we talked about is partly central, it's oxygen delivery, but that won't help if you can't extract it, as you said before.
Yeah, I mean, the only way you can increase extraction, of course, is capillarization which they didn't measure in their studies. All they measured was maximal activity of citrate synthase, which reflects the total volume of mitochondria.
Yes.
So really, this mitochondrial biogenesis is really a false term. We don't make new mitochondria. We hypertrophy and increase the reticulum. Mitochondria in our muscle, as you know, are just this reticulum. The total, it looks like there's more because when you cut it, it looks like you're getting biogenesis, but you're just making more
You're just getting more cross-section cuts.
Yeah.
And you're saying you increase their volume. Have they shown that they increase their volume? Again, it depends on the mitochondrial defect, I guess. But.
Yeah. So citrate synthase is a rough estimate of your total volume density of mitochondria, and clearly CS went up in the mitochondrial patients in a similar proportionate manner to what went up in the healthy individuals.
Amazing. Yeah, because I guess their oxygen delivery was never the problem. So, unlike you, with because your heart ablation meant to deliver more oxygen. Well, but I guess if you're getting more capillaries, that's helping with oxygen delivery. But it's not that. People tend to think your VO2max is your cardiovascular function. But for them, obviously, it's the extraction. And what?
Exactly. Yeah.
And what are we talking about with these mitochondrial? I know you mentioned CPT2. For a fat one. What are the sort of most common mitochondrial?
Yeah, so CPT2 and the beta oxidation defects like VLCAD deficiency, which is the first step in beta oxidation. So those defects are considered fatty acid oxidation defects. And although beta oxidation occurs in the mitochondria, the mitochondrial disorders are those that affect the respiratory chain mainly. So there are things like MELAS syndrome, which is a point mutation in the mitochondrial DNA, which affects a transfer RNA that's specific to leucine in the mitochondria. So you don't build the appropriate eloquent respiratory chain, so you don't extract oxygen. There can be defects, for example, in cytochrome C oxidase, so complex 4 can be affected. Subunits, both nuclear and mitochondrial encoded, can lead to mitochondrial mutations. There is a very common disorder that affects adults, which is a sporadic deletion of the mitochondrial DNA. And as folks on this channel may be or may not be aware, the mitochondrial DNA we get from our mums, and men will not pass it on to their offspring. It contains 37 genes in another transcript called MOTC, but traditionally 37 genes, which are used to make up the core structure of the mitochondria, which is function really is to take the reducing equivalents from food and to essentially, through a series of oxidation and reduction reactions, with the terminal oxygen acceptor being complex 4, we reduce molecular oxygen to water and extract energy. In that way, we generate ATP. So anything that impairs that very elegant structure will cause a decreased ATP generation in the presence of oxygen. And so these patients, usually exercise intolerance is something that most neurologists don't ask about. But when you ask these patients, they say, oh yeah, that's definitely an issue. But most of them will come in with droopy eyelids, optic atrophy, hearing loss, stroke-like episodes, cardiomyopathy, and other manifestations. But exercise intolerance is a pretty invariant and almost exclusive, or I should say, canonical feature of the disease.
And I guess, again, I'm still trying to think. So if you've got this specific defect, how does the exercise improve that? I'm assuming it's not, increasing that cytochrome. If you're missing cytochrome oxidase, for example, how do you get around that? How does the exercise improve the oxygen extraction?
Yeah, if you had a complete null mutation, so for example, you had a stop codon in both alleles, so you made no cytochrome C, it would be incompatible with life. So what allows a person to live into adulthood is not a complete block. So, any complete
you increase the volume, so you're increasing more of everything. So that enzyme, which is not completely, so maybe it's working at 20%. You've got 20% of more stuff.
Ding, ding, ding. Which is really the whole theory of exercise training. We just increase this engine because Mother Nature, has done a pretty good job throughout evolution of the mitochondria for the last 2 billion years to have a pretty darn efficient mitochondria. So for most of us, when we exercise, we don't increase the efficiency of the mitochondria. Our engine is just bigger. And to some extent, that's really what's happening to the patients. They have an inefficient engine. We just make more of the engine. So, you have a 200 horsepower engine running at 20% efficiency versus 100 horsepower running at 20% efficiency. So that's kind of
that's
the
the thing
analogy.
I was missing, because I was thinking they were basically in like they were knockouts. You know, they didn't have that at all, but they've got it maybe working at 20% or something. And now you've got, if you've got double the amount working at 20%, you're going to be much better off. It makes sense.
Yeah, if you had a complete knockout of your mitochondria, it would be game over.
Exactly. Now, the other thing is affect all the, because I mean, I know these diseases don't always affect every muscle. I would just tend to think, oh, every muscle is going to have a problem. Is that actually not true, that it affects some muscles more than others? Or is it more, for example, I know in Duchenne muscular dystrophy, they would tend to die because they can't breathe. And it's because the diaphragm, you know, but is it like every muscle is affected, or are there differences?
Every disorder is a little bit different. Sorry, I'm just texting my daughter here.
No, you're right.
So every disorder is a little bit different. So for mitochondrial disease, you know, all of the muscles are pretty similarly affected. However, other disorders, there is a dramatic discrepancy between the muscles that are involved, and hence it changes our exercise prescription. So for example, in myotonic muscular dystrophy type 1, where we published that JCI paper just last year, the muscles that are most affected are your finger flexors, so hand grip, that's the first muscle. Next is the dorsiflexor, which you were talking about with your experience on the bike. And then finally, it's the tricep muscle. So that's different than, let's say, FSH, where it's the face, the shoulders, and the lower abdominal muscles. In Duchenne, it's mainly the proximal muscles in the hip girdle first, and then the shoulder girdle, and also the diaphragm.
That's so you said that.
Yeah, so it depends on what the genetic defect is and which muscle is affected. We can then design exercises to work on compensatory muscles around those muscles. And because a muscle that's end stage, that's just connective tissue and fat, you know, exercise is not going to help that muscle. It's very similar to post-polio muscle dysfunction, where work from Sweden has clearly shown that if a muscle is completely atrophic and fibrotic, exercise is not a benefit. So to some extent, we use knowledge of the disease to pick what exercises, what muscles, but also from a safety perspective. So someone with FSH dystrophy, we don't want them to be doing weight training over their head, because that's going to damage their shoulder. And often if they're doing activities, we use cables and machines with the elbows in tight to fixate the scapula, and then we do the exercises, being cognizant of their specific entity.
Sounds like you offer an amazing service over there.
Well, we've just put a lot of this on a website that we've created. We first started with an exercise DVD for patients with myopathy, and we were sending that all over the world, but nobody has a DVD player anymore. So we've started a website on YouTube. So if you type in the Neuromuscular Junction with Dr. Mark Tarnopolsky, all of our specific exercise videos are there, both specific to things like inclusion body myopathy, FSH muscular dystrophy, myotonic dystrophy, Duchenne, et cetera. And then we have different programs that people can follow along. If you're really weak, we have chair-based exercises. We have, you know, sort of an introductory to a moderate to more advanced exercise for different myopathies with our exercise technicians. So people, you know, could take a look there at those specifics. But pretty much every disorder that we look at, and that others have looked at over the years, exercise has clearly been shown to be beneficial for most disorders. But there are caveats.
With pretty much every condition you've looked at, exercise is beneficial.
Yeah. So inclusion body myopathy, there is no treatment for it. People tried IVIG, they tried prednisone. But 2 decades ago, first author Spector showed that pretty standard weight training in patients with sporadic inclusion body myopathy, for which there is no other therapy, improved strength by 30 to 80% in some of the muscle groups. So a very dramatic improvement. We've published in myotonic dystrophy showing that those who exercise habitually had much better strength than those that don't. We've since looked at patients with myotonic muscular dystrophy type 1 who came in some cases, you know, could barely last 30 seconds spinning on a bike. And at the end of 3 months of supervised endurance training, we had everybody on the bike 3 times a week for 35 minutes, exercising up to 65% of their VO2 max at that point. And we showed over 30% increase in VO2 max. but more importantly, 6-minute walk test, get up and go from a chair, all of these things that the FDA are using to approve drugs. We were getting improvements of a greater magnitude in the 6-minute walk test than drugs that cost $1 million a year per patient were that are being approved.
Really? For those particular conditions?
For a disease called Pompe disease, POMPE, which is a disorder of lysosomal glycogen metabolism. So they miss an enzyme called GAA, which breaks down glycogen in the lysosomes. So it builds up in the lysosomes. They can either burst and then the lysosomal contents can damage the muscle, or they displace the contractile elements. So the therapy that was approved almost 16 years ago in most countries is an enzyme replacement therapy, where in a bioreactor, Chinese hamster ovary cells, which are specifically genetically modified, spit out GAA, it's purified and infused back into those people. On average, for an adult, it's almost $1 million a year for that therapy. And yet, the improvement in the 6-minute walk test was 31 meters. The improvement in the 6-minute walk test with our exercise and myotonic dystrophy patients was greater than that.
Wow.
And interestingly, in patients who were being infused with that enzyme with Pompe disease, when they did a endurance and resistance exercise program by a group in Greece, the improvement in the 6-minute walk test was even greater than that 6-minute walk test improvement from which the original study was used to justify the $1 million a year per patient. So it's incredible, but unfortunately, there's an ethos that if it's not a single small molecule developed in a very traditional way by a pharma company, and you pay $300,000 to $1 million, which you do for most rare diseases per patient per year, it's not a real therapy. So unfortunately, the whole ethos of exercise as medicine is something that I've been a proponent of, thanks to the great work by Frank Booth and others. And it really is such an effective therapy for our patients.
That's amazing.
Provided optimal nutrition, knowing the disease, knowing how to exercise properly, and all the precautions are taken, people can exercise.
Well, I guess I just realized maybe why these people aren't actually probably getting told this stuff as often as possible, because their average neurologist isn't going to know all this stuff. Is that right? They're not going to understand the metabolism, the muscle, the diet, the whatever, as well as they need to, or are they? Maybe I'm wrong. Maybe they are. Are people actually telling them to exercise rather than spending $300,000 or $1 million a year?
Well, I think it's people are starting to become aware of this. So, for example, in the Netherlands, which there's a founder effect with Pompe disease, they have the highest incidence in the world, and their group is very progressive. They were the first to discover this enzyme replacement therapy, but they're very keen to exercise the folks as well. And they've actually put out another paper recently showing that exercise class physiotherapy, they call it, actually improved function quite significantly in their patients. So people are definitely coming around. And there's more and more papers. I mean, John Vissing's published at least 8 papers in different types of limb-girdle muscular dystrophy in myotonic patients and FSH, showing improvements in fitness, improvements in function when people do exercise. So that's just becoming more and more accepted in the neurology community as a therapy. But there still are the old school folks, and I don't know how many patients come to see me. Well, my physiotherapist said I need to learn exercise conservation. I need to learn to conserve my energy, and I want to brace. They want to put me in a wheelchair. They want me to move because I'll damage my muscle. And I hear this still far too often in disorders which clearly have been shown to benefit from exercise. Again, just an anecdote, but from a Duchenne perspective, there's 2 interesting anecdotes. One is we had a fellow who came to me now almost 18 years ago, was diagnosed with Duchenne when he was about age 3, and his parents were very reluctant to start on corticosteroids, but his grandfather was a yoga master. So every day, 2 hours a day, he would stretch, do yoga, and get him into walking and biking. The guy never took a corticosteroid. Obviously took my creatine and had good quality protein. At age 21, he could still walk, whereas most boys with Duchenne without therapy will stop walking at age 10. So again, anecdotal, but time and time again in our Duchenne boys, we do see that we can mitigate some of the obesity they get when they go on their corticosteroids, obviously with exercise, improve bone mass, all of the things that we see in our older adults, we see in our patients in sort of a shortened time frame because they're getting diseased and losing function so quickly when they're young.
So is it fair to say, I'm hoping they get an increase, because of Duchenne muscular dystrophy, obviously people die young, in their 20s, I think, usually. Do they actually live longer, or is it more the health span, like you said, they're actually able to be?
Well, that's a very good point. So when I started my career back in 1996, my first clinic that I ran, on average, boys were, young men. They were in their early to mid 20s, as you pointed out, when they would die, usually from either respiratory insufficiency or cardiac insufficiency. We still rarely get some people dying in the early 20s, but I did a lit search for a medical legal case I was involved in, and I looked back on our patients. Our average age at death is now mid 30s. So there's no new gene therapy. There's, and people are talking about exon skipping, but none of our, 1 or 2 of our kids are on it in research, but it's really not doing very much for them. What's changed in those, 25 years? It's exercise, nutrition, attention to detail, stretching, optimizing the nutrition, making sure the protein intake is adequate, making sure they're not vitamin D deficient, doing all the proper exercise. I think these things are, I can't think of anything else that's improving their functional capacity and their lifespan other than.
That's amazing, because that's 40% or something more. And is there anything that goes the other way, where there are pharmacological treatments that actually are better than exercise? That's the other way to go.
Well, the standard of care in Duchenne is corticosteroids, which, as you know, are prednisone. But the problem with corticosteroids is type 2 fiber atrophy, osteoporosis, dysglycemia. And if we think about dysglycemia, yeah. Sorry. Yeah. So when we think about that, let's say, all right, let's think about what we know about exercise physiology. We know that exercise is beneficial from a bone mass perspective. We know that exercise is a very important countermeasure for dysglycemia. We know that exercise, and good nutrition are countermeasures for obesity, at least prevention of obesity. And that's what happens to our patients. They get obese, they get dysglycemic, they get osteoporotic, and they get type 2 muscle fiber atrophy. And all of those we know from many, many, many exercise physiology studies are beneficial. So right off the hop, one would think that this is something that we should be prescribing to our Duchenne boys. The reluctance is the mouse model. So the MDX mouse model of Duchenne dystrophy, when people first started to look at this, what they did is they ran them downhill on a treadmill. So they did eccentric exercise on the mice and said, oh, look, they're not recovering as well. So people then said exercise is bad for you. But we published a study, almost 20 years ago, where we exercise trained MDX mice in an appropriate manner on a treadmill, gradually ramping them up, not doing downhill activity. And they had increase in antioxidant enzymes, they had increase in mitochondria, increase in function, increase in grip strength. And no child, I swear on my whole life, on my kids' lives, no child with Duchenne is going to do eccentric exercise on a crazy treadmill at high intensity.
Running downhill.
It's like cattle prod to get them to do something.
So they just did that to get the effect they wanted to see, because you don't even start, I never think, and I've done rat and mice studies, I never think, oh, I'm going to train a rat or mice, oh, let's do it downhill. So it sounds like they were doing it to try and get the effect.
It's ludicrous, but that ethos carried on, and it was dramatic when I first started my career 25 years ago. It was taboo to recommend exercise for Duchenne. Right. You'd probably lose your license if you told a boy with Duchenne to do activity. Another anecdote, again, there are studies in Duchenne and good work by John Bissing in Becker's, which is sort of the milder form of this, showing beneficial effects. And we've shown it in the mice too. But we've had patients where one of the boys has ADHD and the other one doesn't. So in those cases, at any age, the boy with ADHD generally does better than the boy that doesn't, because they're more active. They run around more. Which is interesting. It's just activity. It's
not the red lemonade they're drinking. People always talked about red. You're hyperactive. You're drinking too much red lemonade, red cordial. I've just got a question here I thought I might ask from Twitter. Mark Preben-Lindenbach, who's great, he always sends through questions. I think we've probably talked about this. What modalities of exercise have the best effect of benefit in myopathy? So I guess it depends on the myopathy. And what exercise modalities have yet to be investigated? Does the exercise modality or intensity even matter, or is it the volume of exercise that drives the beneficial effects in patients with myopathy? But
Yeah, so I think what I don't think what has been most studied for sure is endurance exercise. So John Vissing has shown that in various forms of limb girdle in Becker's and FSH. We've shown that very well in myotonic dystrophy, that we can improve fitness. So there's no question that regular endurance training is helpful. And again, most of the studies have used very traditional stuff that we would use for a middle-aged or an older sedentary person, starting off at 50% of VO2 max, gradually trying to get up to, 65, 70% VO2 max, aiming for at least, 3 times a week for 35 minutes. When we did that in myotonic dystrophy patients, dramatic improvement in function. What we didn't see in our myotonics, which most people aren't finding, is an increase in strength. So function improves, which is really what people care about. Can you get up a flight of stairs? Can you get out of a chair and walk around a pylon 10 meters? So that improves with endurance exercise.
Strength.
But when we measured on the Biodex dynamometer, we saw no increase in strength. Now, the French group, so there's a big population of myotonic dystrophy patients in Quebec and Canada. They've done some wonderful work starting to do more resistance training, and they've clearly shown improvements in strength. And again, it's those important things that they're missing, because grip, if you lose your grip, really starts to impact your daily activities. So just regular, with the hand grippers, doing 3 sets of 12 repetitions will improve strength. Now we're following up on this to combine both home-based mixture of endurance and resistance exercise and myotonics with optimization of nutritional intervention with good quality protein. Again, work that I learned from work that Stu's done with whey and casein to increase synthesis and decrease degradation, plus work we've done with creatine, mixing these all together with optimal exercise. So more is coming, and all the work that we've done on aging over the years and everything, when I take the world literature together, I really think that endurance plus resistance in individuals with myopathy is ultimately the best thing. Now, a little trick, which gets to this point, is with our mitochondrial patients. Some patients have severe exercise intolerance with low VO2, but we've also, in those individuals, found that they can usually do weight training and resistance quite well because it's anaerobic. So many of our patients with a horrible VO2 tolerate, 3 sets of 10 repetitions because it's anaerobic.
I guess they recover slower though between the sets.
Right. So what you do is you have to be exactly the point. Instead of the usual 2 minutes for creatine phosphocreatine to recover, we try to wait 6 minutes. So we do a massive circuit. So instead of 3 exercises and start your circuit again, you do 8 exercises.
Blow it away and then rest.
And go back, so that they've got like 6 to 8 minutes to recover their phosphocreatine. And we, of course, put everyone on creatine as well, which we showed years ago improved high intensity.
And that's the cool thing, because it actually fits with, I'm a big fan of like circuit training. Like why do like bicep curl and then stand around for 5 minutes, then do another bicep curl? Why not just do your upper body then lower body? And you're basically saying that blow away, because you blow away your creatine phosphate in one muscle, blow away another muscle, blow it away another muscle, blow it away another muscle, and then recover and do it again.
Exactly. Yeah. And of course we creatine load our patients as well.
Right. And I guess we haven't officially talked that much about the nutrition side. I guess you've said creatine, but you said something about you have a mix of supplements or something. Yeah,
certainly for mitochondrial patients, we published a randomized double-blind crossover study back in 2007, where I expanded on a hypothesis I put forward in 2001. And that is that with mitochondrial dysfunction, there's multiple issues that happen. We have increase in ROS production, reactive oxygen species. We have a decrease in aerobic energy transduction. And in some cases, there's bypassable strategies. So for example, if you have a defect in complex 1, provision of coenzyme Q10 or riboflavin can help you to increase reducing equivalence distal to complex 1. So what we hypothesized is we had coenzyme Q10, alpha lipoic acid, which are both mitochondrial antioxidants, which also provides something called a redox couple, vitamin E, which is a membrane-bound antioxidant, and then creatine, which helps improve the creatine phosphocreatine shuttle, but also gives you that alternative energy source. And what we found is that we lowered lactate, which is an indirect measure of improved mitochondrial function, and we lowered 2 markers of oxidative stress, which is felt to be part of the pathophysiologic mechanism is why they have damage. So then people criticize my study because they're so focused on pharma. And they're saying, well, what's the mechanism? You've got to tell me which one is doing it. And I said, well, we designed it specifically to target the multiple
not one
pathways.
thing. Yeah.
And so I listened to people, to the naysayers, and we put people on very high doses of coenzyme Q10 because everyone said that's what's driving it. We saw no benefit, no reduction in oxidative stress whatsoever. So definitely, multi-ingredient supplements are of benefit in certain disorders. And what's interesting, and we're now starting to take that mitochondrial core, we call it, and apply it to other disorders. So there's very good work now in FSH muscular dystrophy showing mitochondrial dysfunction and increased oxidative stress. And a lovely study, which didn't get much press, came out of the Montpellier group in France, showing that a 4-ingredient, mostly antioxidants, including some selenomethionine, improved function in FSH patients. So again, targeting mitochondrial dysfunction and oxidative stress, which are really final common pathways, which are similar to sporadic inclusion body myopathy, FSH muscular dystrophy. And we were the first last year in our JCI paper to show the myotonic muscular dystrophy patients have a dramatic mitochondrial impairment. So I don't know if you've looked at our study, but we did high resolution respirometry, we did RNA-seq, but everything was pointing towards a major energy crisis in the muscle, even though the fundamental genetic issue is really one of RNA toxicity, that the RNAs actually don't migrate out of the nucleus. And so you get abnormal transcript effect of RNA proteins. Yeah. But at the end of the day, it's something targetable, and that's poor mitochondria. Crappy mitochondria make ROS, more reactive oxygen species causes damage. So mitigating that by exercise, which increases your antioxidants endogenously, improves your mitochondrial function. And then I always say that that's the core. We exercise, and then the different supplements can be icing on the cake.
Perfect. So have you done the classic sort of, no exercise, no supplements, supplements alone, exercise with supplements? Or is it too hard when you've got these small and, like not many?
It's really a challenge because one, it's hard to get the funding. We're very fortunate that our study that CIHR, our granting agency, gave us for a short period of time a relatively unrestricted fund. They said, okay, you've done good research, we trust what you're going to do.
Well, that's refreshing, isn't it? Yeah.
It's rare. Fortunately, they canceled it. I don't know why. But that's where we did our study on the myotonic dystrophy patients to discover this incredible mitochondrial issue that was going on. So then we applied to come up with an optimal multi-ingredient supplement for myotonic dystrophy patients. We're successful, and we're just about to start that in the next couple of weeks. But again, these are very challenging studies to do because there's a real lack of funding, and you can't patent the darn stuff. So if I discovered creatine and I biosynthesized it and I called it Mark Tarnopolsky 131 and sold it to Pfizer and had the patent on it, if you think about all of the benefits of creatine across multiple studies throughout the world, I'd be a billionaire right now. But because it was a non-patentable molecule, people poo-poo it. And I'm sure there's a massive negative bias from pharma because they don't want exercise. They don't want multi-ingredient supplements. They don't want to know anything about creatine because anything that works is taking away market share from these companies. So there's a massive negative bias towards any of this stuff, including exercise.
People that have seen quite a few of my podcasts will notice I'm not always a big fan of supplements. I quite often say if people are having a healthy, balanced diet, they don't need supplements. So what I'm wondering about is, people might race out that don't have mitochondrial diseases or other myopathies and think, right, I've got to get, they're writing down the shopping list, the creatine, coenzyme Q10, et cetera, et cetera. What do you think about that? The people, normal healthy people, do they need to supplement these things, whether they're exercising or not?
Yeah, that's an excellent point. So clearly the issue is that folks come up with, supplement here, supplement there, and, they market it well and they sell snake oil, and it's pretty much useless. There are a few supplements which have been tried and tested. And if something has not undergone a proper randomized double-blind trial, and if it's not discoverable in PubMed, don't believe it. So I'll just put that out there first and foremost, because, in full disclosure, because of all of the work we've done, I did start a company. I'm the founder and CEO of something called Exerkine, and we do have a supplement division, but our supplements we're spending millions of dollars doing proper randomized double-blind trials, but getting zero credit for it. And people are hand-waving and coming up with crap and making false claims. And it's really frustrating because we raised all this money. We actually, Stu Phillips was the one that came up with the first supplement for aging. And this is for sarcopenia in people over the age of 65, where they used creatine, calcium, vitamin D, and whey protein and fish oil, and showed that compared to collagen, this was far superior in terms of improving strength and function, lowered inflammation and such. But what's interesting is the placebo in that study was collagen. And yet, if you go out there, collagen is so heavily marketed that I imagine most people, the lay public, would think that collagen is the best protein out there. But it's horrible biological value, and that was our placebo. So we actually bought the patent off of Stu and Marty, and we reformulated a little bit based on some biological principles, and showed that there was a greater strength gain when people did weight training. So yes, there is a disorder, aging-associated sarcopenia and weakness. When you train with an optimal supplement, you'll gain a little bit more versus taking a placebo called collagen. For mitochondrial enhancement, again, if you don't have mitochondrial dysfunction, there's probably no benefit to improving it. As I pointed out earlier, Mother Nature over 2 billion years has selected this beautiful, perfect mitochondria. What we can do with it is make more of it, and the best way to make more of it is with exercise. And so taking an antioxidant, if you don't have increased oxidative stress, can actually be deleterious. So there have been studies where people have taken vitamin E and vitamin C together, and these were middle-aged individuals who started doing weight training and endurance training. And what they found is that the canonical adaptations in terms of increased VO2 were actually attenuated in those that took the supplements. So I would certainly caution anyone who's otherwise healthy to take certain supplements that have not been studied. Because in the PNAS paper, Risto was the first author, there was a clear blunting of the adaptations to exercise. And we know that exercise is by far and away the best proven supplement. Exactly. It increases antioxidant protection, it increases your lifespan, it increases your health span, and anything that would blunt that, you've got to be careful of. So certainly for our patients too, not one supplement fits all. So for mitochondrial disease, we chose those 4, but for FSH muscular dystrophy, we're working on a combination for those patients to increase methylation, and there's various other things that we're putting in. But again, nothing our company promotes unless it's been studied first in preclinical models and then in a randomized clinical trial for the indication which it was specific. Yeah.
And then even something like creatine, I guess, quite a lot of people take creatine supplements. They've been shown to work, definitely, can increase strength, size, etc. But you're probably better off, that's the icing on the cake, as you mentioned earlier. Exercise training will do it. And then, do you really need to supplement? You know what I mean? Like, sometimes they're doing it as a bit of a shortcut. Oh, maybe I won't have to do as much weights, but I'll get strong if I, do less weights plus creatine.
Yeah, no, I've always used the term icing on the cake. And, I've been doing this for 30 years, and it's pretty clear that, 80 to 90% of the benefits we see in aging, in muscular dystrophy, in mitochondrial disease is the specific exercise. Exactly. And then making sure that the protein intake is optimal, because, some people come in and they're this new kick and they're vegan, and they don't know how to combine their proteins properly, and their protein intake is suboptimal. You will not get optimal gains. So the first thing is proper exercise with optimal nutrition and making sure that there's no deficiencies. In Canada, for example, 15% of our patients, when we measure them, are severely vitamin D deficient. So that's neither good for bone, nor is it good for muscle adaptation. We've even had people come in with, high CK and muscle weakness, and all we find is that they're severely deficient in vitamin D. You replace it and they go back to normal. So, there's a lot of factors that go into that, but shortcuts never usually work.
Now, thanks. Before you did a disclaimer that conflict of interest, etc., with the Exokines, but I do actually have a question from Mitch S on Twitter. Where does the current literature stand for the therapeutic potential of Exokines in the treatment of neuromuscular disorders?
Well, there's nothing that's been shown to be of benefit. And as I pointed out, and it was published in our FASEB paper, that my company lost several millions of dollars and we went bankrupt, and my wife and I had to restart the company based on that observation, like, because we went way down the pathway with in vitro work, and we even had a little bit of animal
with the
success
exosomes. Okay.
with exosomes, yeah. So with the exosomes, like, we were putting Exerkines in them, we were trying to load them with RNA and stuff, use them as therapy, and it just was killed when we had that patient who had the bone marrow transplant. We showed no transfer because he was the perfect embodiment of it. So from an Exerkine perspective, as you know, Bruce Spiegelman started a company. People may not be aware, but Ember Therapeutics was started. I mean, they raised, and this is all public knowledge, $30 or $40 million through a finance group down in Boston to commercialize Irison. That for various reasons didn't materialize. And I think there's a potential for Exerkines to be of benefit. We discovered IL-15 improved mitochondrial function in skin and muscle. And conceptually, it's possible one could give an injection, 1 time, 3 times a week. At this point, we don't really know. But if you think about, the number one drug right now that's all the hype is the GLP-1 receptor agonist. Essentially, it's not an Exerkine, but it's the same concept. What you're doing is you're giving an endogenous hormone in a subcutaneous injection to confer benefits. So once a week, you take this injection of an endogenous protein hormone. It's somewhat analogous to the same concept as to giving Exerkines. So, we haven't abandoned it totally, but we certainly have been working more on the multi-ingredient supplement approach, which has been, following up on Stu's excellent work with Johnny Parisi. For the older adults, I think we've got a supplement that definitely does help people. And we're really working more from an altruistic perspective. And, we won't be making any money on our patients. In fact, we give them discount codes and we actually lose money if we sell anything to patients. So there's anyone who has mustard to contact me. We have discount codes so that there's zero profit for our company, because all of this we want to give back to the folks. But if we can make money from common disorders like obesity and aging and turn it back into discovering new therapies for our patients, that's the ultimate. So is there a role? Ultimately, I think if we could identify a number of these Exerkines, the challenge we have is to know how much you'd have to give with an injection to mimic what happens naturally through Mother Nature. And part of the reason why it's really a challenge is for IL-15, for example, it took us inordinate amounts of time when we saw that it was going up mainly in the trained individuals afterwards to know how much we had to inject into the mice to mimic what happened in our mouse exercises. That's a real challenge. And again, with GLP-1 receptor agonists, I'm a little surprised that you just give it once a week and you get this benefit. With an Exerkine, would you give it 3 times a week like you'd exercise? Would you give it one day, take a day off, and give it another day to get hormesis? It becomes very complicated. And again, to give a subcutaneous injection to know, is it going to go up in the blood to pulse? That's a huge amount of phase 1 and phase 2 clinical work to get there. And again, it would have to be a big pharma play to actually bring one of those to fruition. But it's conceptually of interest, and that's how we started the company, but we realized it's very, very complicated.
Wow. Thank you.
Yeah.
Well, what a great chat. I've really enjoyed this. Well, I wonder if we could just finish up with, sorry, I think we covered pretty much everything you want to get out, do you think? Or
I think we've covered most of the stuff. And if anyone wants any further information, they can go to our website for the Neuromuscular Junction and take a look. We've got most of the disorders covered there. But I think we've hit on most of the key points.
Right. Yeah, I've really enjoyed this. It's been inspirational, actually. I wasn't aware of quite a lot of what you've said, so it's fantastic. What I thought I might finish off with is what I'd like to do is just some takeaway messages. And I guess an important one would be, what do you say to your doctor if they say, exercise will damage, or what was the name of, I can't remember what the name of the topic was here. Doctor said not to exercise or whatever it is. What should they say?
Well, I think it never helps to confront doctors. So if somebody is that ignorant in terms of the literature, you're probably not going to get further ahead if you were to say that to them. But I think what you need to do is to seek out the information from the appropriate literature. There's been so much work that's come out. The Danish group, Ron Haller's group from Texas, the Quebec group is doing a lot in the muscular dystrophy stuff. that, don't take no for an answer, seek out the appropriate individuals, but you've got to find a kinesiologist or a physiotherapist. I generally find kinesiologists have the background to understand exercise prescription more, and possibly, especially if you've got a metabolic disorder, a nutritionist or a exercise physiologist or a neurologist who understands the area to help you to come up with the optimal combination of optimal nutrition, optimal exercise, and in some cases, certain supplements can be a benefit, and identification and treatment of certain deficiency states.
And I guess the takeaway is one big takeaway, because I'm thinking already what I'm going to tweet out, and I always say, had a great chat and whatever, is that you're saying that pretty much every myopathy can be improved by exercise in some way, depending on, it'd be a different type of exercise depending on the myopathy. But is that a fair takeaway?
I think there's no question that pretty much every individual can benefit from some activity. Even our men who are in wheelchairs with Duchenne, many of them, we get them a cranking arm ergometer, and that helps to maintain, blood flow. It helps to maintain movement, and also helps to maintain arm function. So I cannot think of a situation when, if done properly, exercise is deleterious. But again, that's the key point: is you've got to understand the disorder, and you've got to listen to your body and titrate up. Very much like we do adaptive activity for those following surgery, for those who are sarcopenic and old, for those with osteoporosis. You just got to know the disease and know how to prescribe the exercise appropriately. And then everyone's an athlete.
Yeah. When you say you've just got to know the disease, I've been thinking a few times, you must have to read and read, like go back to your biochemistry textbooks, to actually work through all these different diseases. It must take a bit of time, look at the literature. And
yeah, I mean, there's, you got to have a passion for what you do. Otherwise, you're not going to be, getting all excited. You're thinking on my run, it's like, oh my God, I've got an idea. I've got to, I've got to try this in our next study and stuff. But you're like that. Everyone who's in this area that I've met, has a huge passion for it. I've just been fortunate to have met some great people in my life, and I learned a little bit from these people. I'm a lucky man.
Awesome. Now, I can't help thinking as well, your VO2 max is 70 at 60. So that's the thing, people say, I want to have my max higher than my age. When do you think that crossover is going to happen?
My problem has been a lot of injuries. I've had 14 broken bones. I had my hamstrings ripped off and reattached. I was told I'd never run again. I've since done a 100-mile stage race and a 24-hour adventure race. We're still, it's tough though, because, when you're young and you've got a VO2 like that, and, you're winning all these races and everything, you think you're never going to age. But you look at all those graphs, from all these studies showing VO2 goes down, and boy, I tell you, it sure does.
Well, you've definitely slowed it, because they used to say, 1% a year or something. You've definitely, and then training 0.5%, you've definitely slowed it. But you started at 87, so 87 to 70, that's pretty crap. No, it's still pretty amazing.
Yeah, but it's difficult when you go out. You used to be able to do 3-minute kilometer repeats like no problems on a rail trail, and then you go out and you look, oh my God, I'm running 5 minutes and I feel like I'm going fast.
What's weird? Yeah, you feel like you're going fast. That's the same, because I used to be a runner, and I'd go out and I think, I'm actually running, because I've always had injuries. I'm actually running. I look down, my feet were the same. They look the same as they did. I feel the same, but it's like 1 minute a K or more slower. It's like, what the hell? Is that what you feel as well?
Oh, absolutely.
You look down, you go, I'm sizzling, and then it's like, hang on, it doesn't feel right. It feels the same somehow.
Yeah. I know. Like I go out and I do, the same run on the weekend, and normally it'd be an hour and 36 for this loop that we do up in Pretty River. And I did a race last week, a 6-hour running race, but nevertheless, a week later I went out. It took me 2 hours and 15 minutes to do the same loop. It was just evil. But and the other thing too is recovery as we age too. If we had to, you could do a back-to-back 25K, when you were young. Ideally 2 weeks is good, but last week we did the 6-hour race, and I'm telling you, on the weekend I was literally going downhill backwards a week later.
Out of interest, you're saying this aging mix of, here's a guy, me, who's not big into supplements now. I'm asking you more about that. Do you take any of your concoction of supplements? Does it help you?
Well, I shouldn't be saying this, but I mean, there's no doubt that, for me, I've taken a lot of hits, 14 broken bones, 3 cardiac surgeries, blah, blah, blah.
Yeah.
And I've also had several significant head injuries. You probably can't see, but I've got a huge gash on my head here. I had double concussions, unconscious, had an epileptic seizure on the floor from hitting my head so badly. So I've said, screw it, I'm going to try these things. So again, totally anecdotal, but the supplement that Stu and Johnny first came up with the creatine and all that stuff, I started taking it about a year ago, just a half a scoop per day. So I'm only on about 2.5 grams of creatine. Good quality protein because I work so hard during the day. I usually don't get lunch, so now I'm trying to bump my protein intake up. And then I've been taking a tablespoon of our fish oil. And then I take a half a dose of something called TRIM7, which we showed in obesity activates mitochondrial, causes biogenesis. So I took a half a dose of that, and the clarity, and all anecdotal, but clarity of thought has definitely improved quite a bit because I sort of had this haze too, especially after my last head injury. My hair is
last head injury. So you've had more than one injury.
Oh, I've had multiple, yeah. But my hair is growing. Like my wife has to cut my hair every 2 or 3 weeks. But we're proving this in a clinical trial. So Michaela DeVries, who did a PhD with me and a postdoc with Stu, is now a professor in Waterloo. So she's actually taking this Muscle 5 formula and this TRIM7, and we're actually measuring hair and fingernail growth, which is kind of
well,
cool.
that's what you need. That's where you'll make some money if you can get people's hair back.
I know it doesn't matter about strength and function. And
don't worry about mechanisms. That'll get them in. Yeah.
But the other crazy thing too is, which we're now starting to study in a disease called Leber's. I was developing a cataract after my last head injury because I hit my eye so badly. And my wife still doesn't believe me, but 4 months after being on all these supplements, my cataract has gone away in my right eye, which interestingly, cataracts are mitochondrial dysfunction and oxidative stress. And she didn't believe me, so I went to my ophthalmologist. And they took a look because I wanted to get this cataract out, but I was up north saying, God, there's no more rim around any of the lights, and completely gone. So my cataract totally.
Well, I'm glad you have said it was one anecdote or whatever, but that's pretty interesting anyway. And you're a happy man, so cool. All right. Well, thank you very much for coming on. It's been great. And I'll see you next time. And, well, actually, you did say you could come on again, but I don't have to hold you to it. But we didn't mention that. You said, what was that one again?
Oh, we've done a whole bunch in sex differences in metabolism and a whole bunch of different areas.
Well, maybe I'll pin you down again. But thank you very much for coming on. I'll see you next time.
Yeah, you're welcome. Thanks a lot. Have a good one.
Bye-bye.
I hope you enjoyed this podcast. Please like, subscribe, pass it on to your friends and colleagues. Check out the other podcasts. Thanks again.